Bottom right.
Ah, fine. So will give me a count to go live.
You may start your session, sir.
Good evening, everyone, and welcome on this platform for a wonderful webinar on World Sjögren's Day. I'm Vijay Thorat, working with Hetero Healthcare as GM Marketing for ASRA Division. Hetero Healthcare, an innovative pharmaceutical company working dedicatedly toward bringing pharmaceutical solutions in various therapeutic segments and providing solutions to the customers like our patients, doctors, and chemists. We thrive in our endeavor to give solutions all throughout the therapeutic segments. Since inception in 1993, the company has tirelessly worked in various therapeutic segments, beginning from virology. We call as for the matter virology experts fighting the HIV pandemic. Recently, we have seen a couple of years back the pandemic of COVID, where we were the first company to provide remdesivir. We were in the lead to give the first molecule, molnupiravir, nirmatrelvir, and various other molecules. So as a pharmaceutical company, we have been always striving to give solutions in terms of to the patients and the clinicians to take care of the patients in various therapeutic segments, right from oncology, gastroenterology, hepatology, and bringing in new molecules to the country. We have also innovated the older molecules in the DMARD segment, where we have given a solution where it can take care of the patients for accidental overdose of methotrexate. But this platform majorly is today for an event which an annual event we can call World Sjögren's Day. 23rd July is observed as a World Sjögren's Day, and we have gathered over here to learn more about it because Sjögren's is a silent but serious condition. Don't delay, connect today. But to talk on this, we have an extremely privileged to have an expert to talk on this subject. And let me introduce him today, and is none other than Dr. Upadhyaya, Sundeep Upadhyaya, sir, who has been, just give me a moment. Uh, Dr. Sundeep Upadhyaya, sir, is working with uh, Apollo Hospital. He has done his DM rheumatology, and any introduction would be really short of what I would say about him. He has an expert in this the rheumatology segment, and his expert areas spondyloarthritis, psoriatic arthritis, and various immune conditions. It has been pleasure working with sir on various segment too. I'll request sir to please open up the talk and deliver his lecture.
Thank you, Vijay. So at the outset, I will want to tell you offhand that the problem of Sjögren syndrome is not just the seriousness, but also the very big spectrum that we have, right from a very mild disease to the extremely severe disease, and sometimes even life-threatening disease. So with that spectrum and the number of different problems that we have, I will want to open up a case and show you and walk you through one single difficult scenario. And this happens to be a very typical serious case of Sjögren syndrome. Now, this is something that my registrar presented recently, and Anushka Agarwal, and I'll be taking her slides. She is a housewife, 54-year-old lady, and has tingling numbness of both lower limbs, difficulty walking, and change in gait 1 year. She was apparently well about 1 year back when she started to feel tingling in both feet. There was slippage of slippers, difficulty in ambulation, and she used to feel as if she would fall down any minute because it was as if she was walking on cotton wool. This was associated with a change in gait noticed by the family. Over a period of year, this involved the entire leg, and she had to drag to walk her feet. So a middle-aged lady who had some symptoms, we'll go to that very soon, and after which she had a very peculiar constricting band-like sensation. below the breast with burning sensation, and ataxia and uh, you know sensory neuropathy, very severe sensory neuropathy, burning of feet, tingling of feet, and inability to sleep properly because of these symptoms. Most of her symptoms did not point to lupus or some other illness. There was no evidence of viral illness, bladder bowel involvement. And it seems that the patient had had a past history of small joint pain, which is small joint arthritis. And there was morning stiffness. She had dry mouth, dry eyes. She had dental caries, several tooth procedures. And with that, she was diagnosed with Sjögren syndrome. Although she took treatment off and on, but she never took a very formal treatment till the time she presented to us. And when we evaluated her and found that the background of Sjögren syndrome presenting with lower limb peripheral neuropathy, ataxia, and ambulation problems, and a peculiar band-like sensation. We evaluated for transverse myelitis, uh, NMO spectrum disorder, and also the possibility of an overlap with multiple sclerosis. So over this period, some of these neurological findings were as follows, as shown here. And we were able to see that there was uh, a difficulty in some of these motor examinations. Sensory examinations seem to be also affected abnormally. So lower limb weakness as well as sensory problems. This was the dryness of the mouth, dental caries that she was not treating very regularly. She was off and on methotrexate and such other medications. But the problem that she was presenting was very severe ataxia and peripheral neuropathy. So we've seen the oral cavity picture. We've uh, reviewed some of her musculoskeletal exam findings, respiratory system, and cardiovascular system. And with all that, we made a diagnosis of transverse myelitis with a background of Sjögren syndrome. Investigations were all okay, except that the 2D echo showed a little bit of a pericardial effusion. The rheumatoid factor was negative and CCP was negative. The anti-nuclear antibody was very high titer, and the extractable nuclear antigen Rho52 was very high. So that, along with the features of dry mouth, dry eyes, and the joint pains, confirmed that the background illness was Sjögren syndrome. And to top it up, there was a neurological syndrome that needed to be evaluated. The neurological syndrome was evaluated by the MRI. She showed up with focal T2 hyperintense signal in the spinal cord opposite D1, D2, and D3 vertebral level, likely demyelinating lesion. And there was some problems, minor problems with lower limb NCV. The MRI picture, which is highlighted as an area of demyelination, and the summary of this situation is chronic symmetrical bilateral lower limb weakness, sensory loss with sensory level at D4, bladder bowel involvement. And I am not able to scroll through the last line because this is okay, right. So background of arthralgia sicca with antibody positivity. Why is this stuck? So can somebody help me with
Ravali, just check in.
why is this not going forward?
So that's what happened in earlier also. So it's moving now, sir.
Now it's moving. So then we wanted to evaluate for NMO spectrum disorder. Now this is a close differential with multiple sclerosis, and the fact that there were no visual symptoms, we thought of also looking at the possibility of NMO spectrum disorder, and we did indeed find that there was an NMO spectrum disorder associated with the Sjögren syndrome, and the MOG antibody was negative, but the aquaporin 4 was positive, which confirmed the NMO with Sjögren syndrome, acute on chronic transverse myelitis with Sjögren syndrome. Okay, stuck again. Sorry about why is
Problem,
this
sir.
stuck? Why is
There is
this not?
some technical glitch, maybe.
Okay.
It's moving, sir.
So I won't go into the details. The idea is patient then responded to rituximab. She needed methylprednisolone. She needed a lot of uh, physiotherapy, and the strength regained by 30 to 40%, but never came back to 100%. So what I'm trying to emphasize is that there is a element of seriousness to this illness that can sometimes be dramatic. And it's not just the neurological, but sometimes you can have ILD, you can have uh, patients having renal diseases, something that is a renal tubular acidosis, which is another serious illness. You could have hypokalemic periodic palsy. And with that, I'll go to the formal presentation. What is Sjögren syndrome? Dry mouth, difficulty eating and swallowing, burning sensation, altered taste in the mouth, oral ulcers, poor voice quality, uh, progressive dental caries, chipping, breaking, and loss of teeth, and sometimes candidiasis. Keratoconjunctivitis sicca, that's dry eyes, burning or redness in eyes, grittiness, sand-like sensation, blurry vision, and a lot of other lacrimal issues. Swelling and stiffness in the joints, fatigue, vaginal dryness, sleep disturbances, poor concentration, memory problems, dry cough, hoarseness, dry skin rash, and sometimes pulmonary problems like bronchitis, interstitial lung disease, and pneumonitis. Systemic complications can be fatigue, sleep disorders, anxiety, depression, arthralgia, and chronic widespread pain. Very commonly, we call this fibromyalgia syndrome. And a lot of times we miss fibromyalgia syndrome. We misdiagnose fibromyalgia syndrome when actually it is Sjögren syndrome. So a lot of times women present to us with fatigue, joint pains, low-grade fever, and very minimal dry eyes or dry mouth. And if you miss asking leading questions about joint pains, joint swellings, and sicca features, you might miss Sjögren's in the background, and you might misdiagnose this at fibromyalgia. A lot of patients present with episodes of paralysis, complete hypokalemic periodic paralysis, and that's a very dramatic presentation of Sjögren syndrome. Interstitial lung disease, patients who have had very minimal dry eyes, dry mouth, sometimes they have ILD. And the only uh, indicator of the background of Sjögren syndrome is the anti-nuclear antibody, the anti-Rho antibodies. So other than the lung and the kidney, some dermatological manifestations that are very peculiar are what is called hypergamma globinic purpura. So the patients will be up and about doing their work, and suddenly they'll have lower limb inflammatory lesions, bright red purpura. Most of them are non-palpable. Sometimes they can be palpable, and there's a lot of burning and itching. These are benign in nature, but the very florid manifestations make them very awkward for the patient, and they worry to no end as to why this keeps happening again and again. Uh, Cardiac and nervous problems are also reported, but they're not so important on a day-to-day basis. So chronic tubular interstitial nephritis, that's renal involvement, renal tubular acidosis. Hypothalamic periodic palsy is something that we've just discussed. GI disorders, hematological disorders. What is very peculiar is the presence of persistent swelling of a parotid gland. And to come back to the symptomatology of Sjögren syndrome. So a lot of times people with Sjögren syndrome present with painful swelling of the parotid glands, fever, and only steroids help in that situation. So this is not infective parotitis, but is exacerbation of Sjögren syndrome. Many a times these swellings become chronic. They remain for years together, and an asymmetric enlargement of a lymph node or a swelling of the parotid gland could well mean that this is an underlying lymphoma. So, uh, there are patients, we have about 2 or 3 patients presented with lymphomatous change in their parotid glands and their in their lymphatics. So that's another serious complication of Sjögren syndrome. Pregnancy complications are also known, and they could be miscarriage, preterm deliveries, etc. So, what are the risk factors of Sjögren syndrome, especially younger individuals, about 40, and sometimes even children? Women are 10 times more likely to develop Sjögren syndrome than men. There could be a background of rheumatoid arthritis or lupus, and once that is the background, this would mean that the patient has secondary Sjögren syndrome. So, patient who has rheumatoid arthritis, lupus, then develops dry mouth, dry eyes. That's secondary Sjögren syndrome, secondary SICA. And up to 50% of patients with Sjögren syndrome have other autoimmune diseases. Pathophysiology, there are some HLA factors which relate to the immune activation, female sex hormones, environmental agents, and viral infections. So hepatitis B, hepatitis C, and HIV, these are some viral infections that can cause Sjögren syndrome. There are other diseases like sarcoidosis, IgG4-related disease, and even the use of antihistaminics, the presence of chemotherapy and radiotherapy to the head and neck area. All this can also cause Sjögren syndrome, and they can be triggers for future SICA symptoms. So some of this would qualify as secondary Sjögren's, but the primary Sjögren's is obviously the one that's idiopathic and comes on in a relatively young lady with dry eyes, dry mouth, and arthralgias. So going back to the pathophysiology, we have an immune response. We have activation of this immune response in the glandular cells. So there is infiltration of lymphocytes that go into the exocrine glands, especially the parotids, the submandibular, and several other organ systems, including some of the digestive glands. And they produce interferons, cytokines, and matrix metalloproteinases. There is activation of B and T cells, formation of abnormal antibodies, and all that in general leads to autoantibody formation or a profusion of autoantibodies, very high titer of the ANA, and sometimes the rheumatoid factor also. This amount of inflammation in the parotids and the submandibular causes the the glands to fibrose and their function to decrease, and which ultimately causes dry mouth and dry eyes. The diagnosis is based on specific antibodies in the blood, including the anti-nuclear antibodies, the presence of the anti-SSA or the Rho antibody. The anti-La antibodies are not so important, but most of the times, if the anti-Rho and anti-La antibodies are both positive, then there's a higher likelihood of definite Sjögren syndrome. Rheumatoid factor is about 30 to 40% of the times positive. If we specifically test the eye, we are likely to find positive Schirmer's test. We put a blotting paper in the eye and we check for the amount of uh, length of wetness of the blotting paper. And there are some other dyes that are put in the eye, and you can see with special instrument into the eye and see how much of staining of the surface of the um, beneath the conjunctiva is dry. That takes up the pigment very fast. Cyalometry, salivary gland biopsy, and other history-related items have to be taken into account. Repeated use of eye drops, getting up in the night over and over again to take a sip of water, uh, dental caries, they all add up to Sika symptoms. And this is a classification criteria for Sjögren syndrome. It's not important to by heart all of these. They have an importance for a drug trial and would be important for a primary investigator looking at a new drug or trying to find uh, classified criteria for Sjögren syndrome in a given patient. Suffice it to say that it includes a little bit of clinical, little bit of physical, and a little bit of ruling out of other possible diseases. These are some of the differentials. We've gone over this, but what we missed out are, the rare causes like amyloidosis, IgG4 related diseases, even Wegener's granulomatosis. If you have an involvement of the glands in this disease process and the scarring of the parotid and the submandibular glands, there's likelihood of dry mouth post inflammatory sequelae. And some of these drugs that have been mentioned here, nicotine, which is smoking, or the use of tobacco, opioid analgesics, diuretics, retinoids, so on and so forth. This is, how we would approach patient who has come to you with dry eyes and or dry mouth. You try to get to the bottom of the history, which should be about 3 or more months. Look at the possibility of a basic set of evaluations, including the anti-nuclear antibody test, the titer of the antibodies, the Rho, La, the labeled salivary gland biopsy. So this is something that can be done very easily. You have the ENT surgeon take a little nick under the lower lip, inner aspect, and take out 2 or 3 minor salivary glands that are visible underneath the cut. And that can be subjected to staining and immunological studies. And there's something called a focus score on the histopathology that can give us a clue as to whether this is really Sjögren syndrome or not. So a Schirmer's test with the help of an ophthalmologist, salivary flow rate, and these are some of the basic evaluations that can be done for the patient who has a pure idiopathic Sjögren syndrome. Some of these other tests may be required to look at the um, possible involvement of other organ systems, including the kidney, the pulmonary organ, uh, the congenital heart block is something that is found in a disease called neonatal lupus syndrome. So these are young ladies who've had this first or second child, and while in utero, they even if they don't have the full disease of Sjögren syndrome, they make a very high titer of anti-Ro antibodies. These anti-Ro antibodies go transplacentally and cause either a first or second degree heart block, and sometimes even complete heart block in the fetus. And the fetus is born with uh, either complete heart block or sometimes gets congestive heart failure because of the low heart rate. So that's a different disease altogether, but part of the same spectrum of Sjögren syndrome, um, which I didn't mention earlier. How do we manage Sjögren syndrome? We use artificial substitutes, immunosuppressive, immunomodulating agents like cyclosporin eye drops, surgical procedures. Dry mouth may need saliva substitutes, uh, like an oral spray. Uh, we have many companies making an oral spray. Um, the use of pilocarpine uh, is now uh, possible. About 4 or 5 years ago, it was very difficult to procure pilocarpine, which is always out of stock because there was only one brand. We now have several brands, including the one that's made by Hetero. So it's easier now to at least symptomatically treat patients who have dry mouth and dry eyes with pilocarpine, eye substitutes, eye drops, and oral sprays. For more severe illness where there is joint involvement, disease-modifying agents like methotrexate, mycophenolate, mofetil, leflunomide, corticosteroids, and non-inflammatory NSAIDs. So it's important for the patient to have and maintain good regular hygiene, regular visits to the dentist, avoid environments that are very dry, but also ensure that there are aqueous creams and emollients rather than soap for washing. Wear dark or tinted glasses with side panels in bright sunlight to minimize tear loss, and avoid using contact lenses. Use petroleum jelly in the lips and eye ointment on the lids to minimize fluid loss from the mucous membranes. Do not smoke, do not use excess alcohol, and treat candidiasis properly. No treatment has been very effective. Most of the times, we have been uh, using these medications with a positive hope or optimism that they will work to improve glandular function. But most of the times, if the glandular function is lost, it will never come back because that much of fibrosis has happened. And whatever amount of treatment you do for that dryness is not going to reverse the whole situation. So it's very vital to start treating the patient early with disease-modifying agents and even steroids in short courses when there is inflammation of the submandibular parotid or there is a lot of mucositis. Um, the other essentials are to maintain, you know, oral hygiene, sugar-free sweets, chewing gums, artificial salivary products, and like we mentioned, pilocarpine, which is now freely available. Uh, Hetero makes a very generous contribution to this area of medication. Civilidine is not yet available. This is once a day, while pilocarpine is thrice or 4 times a day. Artificial uh, eye drops, artificial tears sometimes are not enough, and one may need to use punctal plugging. You might need to, have the the ophthalmic surgeon uh, fuse the puncta at the middle of the middle aspect of the eye so that it allows the uh, tear film to be retained for longer in the eye and prevents it from going all the way into the nose. Um, for vaginal symptoms, non-hormonal moisturizers, local hormone therapy. For psychological symptoms, with exercise, counseling, and maybe even antidepressants. Systemic treatments may be required as disease modifying agents. And most of the times, the least we should do is use either hydroxychloroquine or methotrexate as a background supplement to the use of uh, low dose steroids in very short bursts when there's exacerbation, pilocarpine or cevimeline as cholinergic agents. And um, for more serious diseases like the ones involving the lung or the kidney, one may need to use azathioprine, mycophenolate, cyclophosphamide, and sometimes even biologic agents. So very often you will have patients who come to you who are not responding at all to any of these agents. And rituximab may be considered for severe systemic disease. So if you have a lot of eye and oral symptoms and it's relatively early in the disease, the patient needs repeated courses of steroids for reduction of inflammation in the major salivary glands, or has ILD, or is not responding joint-wise, then it might be a good idea to use rituximab, although this is not FDA approved for this indication. And one gets a treatment response that uh, is at least better than nothing for the patient. Uh, there, there's a European League Against Rheumatism treatment algorithm. I won't go into the very details of this. This is for a, in, a physician or a rheumatologist who just Sjögren's treatment. So we'll go over some of these slides very quickly. And suffice it to say that what we've discussed informally has been put out in the tabulated form in a formal manner in these recommendations. We'll go over some of the pilocarpine clinical trials. And this is the effect of one single dose of oral pilocarpine on patients with Sjögren syndrome. And there was significant improvement in symptomatology, uh, even with a single dose, 5 milligram oral pilocarpine. Radius of curvature of tear meniscus after 15 minutes, fluorescein breakup time after 30 minutes. And that's how they were able to show that compared to a placebo using one tablet of uh, pilocarpine, how much change that made to the tear film uh, in this study. So this is oral pilocarpine, 20 milligrams a day. That's 5 milligram tablets every 6 hours for the treatment of dry eyes. 32 patients randomized as 1:1, and they found very good results. So oral pilocarpine was able to relieve discomfort related to dry eyes, patients with Sjögren syndrome, and induce favorable structural changes in the tear film. So it's something that helps keep the film thicker, and uh, by keeping that layer of protection on the eye, it prevents the eye from damage. The sclera and cornea are protected by this layer of tear, and this indirectly helps the eye. Significant improvement in oral symptoms with pilocarpine at week 12. significant improvement in ocular symptoms of Sjögren's with pilocarpine at week 12. So this is compared to placebo. And so finally, Sjögren syndrome is a heterogeneous disease that may be associated with systemic complications that impact prognosis. If Zika symptoms persist for more than 3 months, Sjögren's symptoms should be suspected, especially if adverse drug reactions like antihistaminics, antidepressants, and smoking has been ruled out. The virology has been tested. Hep B, Hep C has been ruled out. HIV disease very rarely can cause Sjögren's-like features, should be evaluated. The anti-nuclear antibody and the anti-Ro antibodies are the first immunological studies to be ordered, and one may also resort to a labeled salivary gland biopsy, and that is very specific for Sjögren's syndrome. The management of Sjögren's syndrome should be multidisciplinary. So you should have the eye examined every 6 months at least. If there is too much of scleromalacia or one of these features of eye involvement, then it might need to be tackled by the ophthalmologist with punctal plugging or cyclosporin eye drops. The dental surgeon needs to look at the presence of caries, enamel loss, and one may need to put caps on the enamel. So that's why the dental surgeon, the ophthalmic surgeon, they are very important. Very rarely, the presence of renal tubular acidosis, you need to involve a nephrologist, pulmonary complications, pulmonologist. Sjögren's syndrome can cause transverse myelitis and multiple sclerosis-like illness, neuropathies, and the neurologist is central to partnering with rheumatology colleagues. And therefore, this management of patients with Sjögren's syndrome should always be multidisciplinary, should be individualized, and it should depend on the severity and the type of the organ involved. And finally, it's something that will be discovered or confirmed only if you know about the illness. It's a lot more common than is recognized, and therefore wider dissemination of the knowledge about this disease is very vital. People don't think that this dry mouth and dry eyes are really serious problems. But most of the times, it takes a long while for the woman to realize that this is something serious and different from what everyone is facing. They quite often just overlook Zika features and say that it's just the weather or I'm sensitive to heat and things like that. But it needs an evaluation by the specialist. Thank you very much for your attention. I hope this made sense and it adds to the body of knowledge that you have for the illness. Back to you, Vijay.
Yeah. Thank you very much, sir. Thank you so much. But I would like to basically apologize the audience and everybody for the initial technical glitch which I faced in sharing your CV, sir. First and foremost, sir, I apologize for that. Uh, I couldn't really find out the way. However, sir, we thank you very much for basically making this very complex subject in a very, very simplified manner. Uh, and explaining the audience in a very very simplified way, because any autoimmune conditions are not that easy to be understood. So but there are a couple of questions which has come up which from the audience, like how much Schremer's test Shomer's test would be really helpful in initial screening, sir?
I think it's important. Many a times it may be negative, even if there is dry eyes. But if it's definitely positive, it gives us a very good confirmation that what you are subjectively assessing as dry eyes, or the subjective assessment of the patient's uh, problem, that I have dry eyes,
Hmm.
becomes objective.
Okay, sir.
It's quite an accurate test. If done
Okay.
properly, I think it's very accurate.
Absolutely. So, and there are so many autoimmune conditions, basically, the patients are suffering all throughout the globe and even in India. So, which are the commonest autoimmune conditions where the patients might there are higher chances of diagnosing Sjogren syndrome? Because whether it's RA, lupus, or it could be a wide variety, sir.
Right. So rheumatoid arthritis very commonly causes Sjögren syndrome. So maybe about 1 out of 8 or 9 patients over a period of time will have secondary Sjögren syndrome.
Okay, sir.
That's how common Sjögren syndrome is in rheumatoid arthritis. For
Absolutely.
other illnesses like lupus and mixed connective tissue diseases, um, it is very often found as an overlap. And sometimes patients may have uh, one manifestation of the overlap overcoming the other. So, for example, if the patient has scleroderma for a very long time
Hmm.
and has joint pains and sclerodactyly, Raynaud's, interstitial lung disease, there'll be episodes of sudden, you know, swellings of the parotid glands, and there'll be episodes of very extreme dry mouth, dry eyes
Okay.
persisting for a few weeks, months, and then
Okay.
that goes into remission. So, although it's the most common in rheumatoid arthritis, but connective tissue diseases and the entire spectrum of connective tissue diseases can also have the Sjogren's and Sika features commonly. But
Absolutely, sir.
other diseases like ankylosing spondylitis or even psoriatic arthritis to an extent, uh, most of the other systemic vasculating disorders,
Hmm.
Sjogren's is not a secondary feature.
Okay, sir. Okay, okay. So in that situation, so what could be the duration if a patient is of RA? So, how many, after how many durations the Sjogren's can set up, or it would take some time, years, or
So
it
yes,
depends,
so
sir?
4 to 5 years, 3 years,
Okay,
sometimes several years.
okay.
But it's severe disease, chronic disease that will be the reason for
Hmm.
the development of Sika features and
Right,
Sjogren's.
right, sir. Right, sir. So, any guidance for the audiences or the patients who are watching this uh, to identify earlier so that they can ask proper questions to the rheumatologist so they can reach out, because if there is a problem in the eye and oral cavity, sometimes they may not open up to the rheumatologist. So,
Right,
what
right.
guidance can be given to them, sir?
So if the average physician, orthopedic surgeon is following up
Hmm.
a patient with rheumatoid arthritis, there is always time for a couple of extra questions. And these could be if you persistently ask them if there is a problem with dry eyes, dry mouth, fatigue, or there is a, excessive use of eye drops,
Hmm.
especially for the past 3 months. Uh, some of these features will quickly pick up secondary Sjogren's syndrome. And
Absolutely.
starting early in treatment and being helpful with oral hygiene and other things will at least mitigate the problems of chronicity of the disease. So 3 months is, sometimes the important time. The patient continues to have Sika features for 3 months and above,
Hmm.
despite all you're doing, ensuring that there is no medical reason for dry mouth, dry eyes. Then one should become active and look for either primary Sjogren's, if it's de novo, or secondary, if there is rheumatoid arthritis in the background.
Okay, sir.
And getting an ANA done is something that is not always helpful. Sometimes you will get a false positive result. Patient who's
Absolutely.
had Zika features for 2 months
Mm,
is an antihistaminic, gets an ANA positive. Uh, a physician or an orthopedic surgeon might want to start methotrexate or hydroxychloroquine. So
mm,
that's not the best idea. It's a good idea to have a rheumatologist intervene,
absolutely.
who may or may not order a lip biopsy,
Yeah,
uh, may also go over problems a little more diligently and give an accurate diagnosis. So
absolutely.
there are as many incorrect diagnoses of Sjogren's as
Mm,
there are missed patients with Sjogren's.
I agree, sir. So I was just about to ask you the question, but you've already answered with this about the biopsy and how patient friendly it would be. How if we order for a biopsy, how patients would take it up and they would really go for this biopsy. And if they are not going, then how we can rely upon the diagnosis in that situation.
So most of the times we manage to do with the clinical features, the presence of high titer antibodies. So higher the titer of antibodies, the more likely the chance. Both dry eyes, dry mouth, the presence of a background of illness like a connective tissue disease and
Right.
rheumatoid arthritis, all that would consolidate our um, confidence in the diagnosis.
Right.
But there are times when either nothing works, or even if it works, say for example pilocarpine is not helping, then
Mm,
you want a biopsy just to be sure that is it really an inflammatory illness or there is something else causing the dry mouth. So the inflammation aspect can only be checked with a CRP, with a biopsy,
right.
and it's not that difficult. It's something that feels awkward, uh, but the minute you go and get it done, it's possible. It's only a local procedure. You outpatient local procedure. You get a local anesthetic, little nick, and the ENT surgeon who's developed a habit of doing this will do it in 5 minutes. Uh,
Absolutely.
so we should try to do it
Getting it.
as
And
many times as possible on given patients.
absolutely. So thank you so much, sir. Thank you so much for a valuable time. And really,
Thank
on
you.
this World Sjogren's Day, really sharing your insights and your expertise in overall rheumatic disease, which we have interacted, and especially on Sjogren's syndrome, sir. I thanks the audience for being there with us at past 9 on this working days. That's Wednesday. So thank you so much, everybody, and we can close this session, sir.
Thank you.
Thank you, sir.
Good night, everyone. Thank you,
Good night,
Vijay.
sir. Thank you, sir.
Thank you, Sumit. Thank you, everyone. Bye bye.
So one moment, sir, if we
Right,
can.
sure.
Yeah. So one moment. So I just like to apologize. The recording has stopped because somehow initially after testing the slide was not moving at all.
Oh, right, right.
So
Oh,
yeah,
that's
it happened. I didn't know it. Initially we tried.
kind of.
I did
I
it
think
multiple times.
what was happening is